Welcome, welcome everyone. Greetings. Hope you all are having a wonderful morning, afternoon, or evening, wherever you are. Welcome to this webinar sponsored by Radiometer America. My name is Steve Liu, and I'm joined with my partner, Ivan Tay. We will be moderators for this event. Today, we are delighted to have our guest speaker, Dr. Amir Matushi. A brief background of Dr. Matushi: he completed his bachelor's degree in chemistry from York University in Toronto, Canada, and a PhD in pharmacology from the University of Toronto. He is currently an assistant professor of clinical chemistry and associate director of the Translational Pathology Core Laboratory Shared Resource at UCLA. His expertise is in toxicology, therapeutic drug monitoring, anti-doping testing, and point-of-care testing. The title of this presentation today is called Patient Blood Testing, Assessing Clinical Workflow Efficiency in Point-of-Care Testing and the Lab. So a couple of housekeeping items before we start. You'll probably notice that the mics and cameras are all turned off in the audience, but at any point during the webinar, you may submit comments or questions related to the presentation topic in the Q&A box on the side of your screen or meeting toolbar. It's the button with two speech bubbles and the question mark, so feel free to use it. We'll have some time at the end of Dr. Matushi's talk, and I will be able to read off some of those questions for him to answer. If there are any unanswered questions, we will follow up with them after the event. To make this event more interactive, we'll do a couple of polls during this presentation and to also get your thoughts around point of care testing. When we get to those polls, you'll see them pop up, and you should see it on the meeting stage as well as in the chat tab. So in this case, let's try. In this case, so now that you are familiar with the interface, without further ado, let's move on with the webinar. I'll pass over the mic to you, Dr. Matushi, so that you can take it away. Thank you.
Thank you, Steve, for the introduction, and thanks to both you and Yvonne for inviting me to give this presentation today. And hi, everyone. Here's my disclosures first and foremost. And today we'll be talking about several aspects in the clinical lab, but mostly focusing on point of care testing. We'll start with talking about labor shortage and the fact that, we're always short staff, and how do we go about solving problems of short staffing while keeping up with all the workload and the quality work that we're always required to do. So we'll talk a lot about challenges, processes, inefficiencies in the point of care space. We will talk about test standardizations and little things that we can do so that things are more automatically done or automated in a certain way, and we can sort of manage things remotely, allowing us to do more with less. And we'll take a look at also test data backups, how things are stored into the LIS, and why is it important to have things interfaced, and where we want to actually be based on where we are. So over the last decade, the clinical laboratory industry has seen steady growth in its revenue and volume of testing, which averaged about 3 to 4% a year-over-year growth, with some years experiencing more growth than others, mainly due to the COVID pandemic. There was a big increase in molecular test offering because of COVID and all the testing that was required to be done at the time. But nonetheless, despite past that, there seems to be continued growth in this. And growth also does mean that we have to keep up with the demand and perform testing from a clinical laboratory perspective. We need to hire and make sure that the laboratory is staffed appropriately to keep up with the growing demand. And the challenge that we saw, this was very apparent during COVID and still continues to haunt us, is that there is limited availability of healthcare workers. Because these are highly trained professionals that require quite a bit of time to train. Different states may have different licensures, so it may be more difficult in some states versus others to get enough people into the door. And we also saw that because of overwork, there was massive resignation. So people begin to get work too much, and they were resigning. So we were in this circle where there was more testing, not enough people, and quality of care suffers from this. Healthcare costs also suffers from this. So just some statistics, since the talk is coming out of California, but in California, um, they need at least 500,000 professionals to ensure access to care. And by 2030, there could be faced with a shortage of nurses and physicians. And these are all driven by aspects that we already talked about, but also by aging population, burnout, people leaving, retiring, and all those things. So what has the response been to some of these? There has been a huge drive towards automation, and we hope to save FTEs that way. And by saving FTEs, because we have undertaken this automation journey ourselves at our healthcare center, saving FTEs, we don't usually let people go, we just repurpose them because we are a growing healthcare center, and so are others. So repurposing people can be very useful, but not only that. So with automation, there also comes the incentives of trying to reduce errors that the human can do. Of course, decrease workload and less burnout, streamline processes, make things more consistent, make things more streamlined, and also increase productivity and ultimately save some money and reduce those healthcare costs, which could be very detrimental and beneficial to some of our patients. And also some of the other drivers to try to reduce some of this burden from the clinical labs is point of care testing. I mean, this is testing that is done at bedside, near patient, physician office. So it's not just testing that is done at the clinical laboratory, but it can be done otherwise. And there are some incentives to this testing that make it more feasible than clinical lab testing, which is medium complexity. For example, this one can be waived and medium complexity, and it allows more access to testing. It is defined as testing that does not require dedicated permanent space, but it can be done, like I said, at bedside or alternative testing site. And this has really recently modernized patient care because of its availability. And it's a considerable amount of the market share, 15 billion in 2011. That is a considerable amount of money that goes into this testing. And so just to quickly talk a little bit about this and define it, where is it done? Well, it can be done at home, community pharmacies, healthcare centers, workplace clinics, physician's office. And most of the times I divide this into in hospital or outside of the hospital is what we mostly deal with. So within hospital, we have our different hospital units that have several different types of point of care instruments. Outside of the hospitals, we have the ambulatory clinics that are spread out over our geographical region. But we're starting to offer this in mobile clinics like healthcare vans, which we're going to take a look at. And so this testing can be qualitative or can be also quantitative. We can measure a concentration depending on the type of test, or we can report things as positive or negative. Testing can be waived or moderate complexity. Both have regulatory requirements. Wave testing is a lot more easier to offer right away, quickly, cheaper, than moderate complexity testing that requires more expertise, regulatory guidelines, validation, and things like that. But both of them do exist as options to perform at the point of care. And so why has this become popular? It has become popular for the very reason that I talked about. It can be done anywhere. Because of that, we are able to get results back quickly. Sample volumes can be smaller. And the fact that there's wave testing that can be done in this setting, it alleviates some work from those clinical laboratory scientists, which are licensed and certified, which are very precious and hard to come by because now an RN, for example, can perform the testing. And like I mentioned, the shortage in healthcare worker has definitely been a top ticket item in our industry for quite some time now. They can be cheaper. Now, on a per test basis, they're not cheaper, but if you want to offer a test right off the get-go and you have a solution for wave testing, which is generally a smaller instrument, the upfront cost of offering the test can be cheaper. If you are able to offer this in a hospital and you make decisions that enable you to use this testing to discharge the patients earlier, that overall cost will be cheaper. But like I said, on a per test basis, these are not cheaper, so that could be seen as a disadvantage sometimes. And the other things that, some challenges with this testing is that there are usually different in methodologies between this type of point of care device and the central laboratory. And there are doubts with some of these results some of the times. They get brought up to us, we investigate them all, we do comparisons, and we address them as they come in. But the reliability of the results can be questioned. However, you actually have to run the test as instructed. And training is a key issue here. And we spend a lot of time focusing on that. And you have to follow the manufacturer's instructions. And also, obviously you don't want to have a test where, for whatever reason, the results are discrepant or even wrong, and then that can lead to a worse outcome. So there's definitely some challenges that we try to work on in this space to standardize and how we can best improve this testing. But nonetheless, the trend has been to move and more towards point of care testing from the hospital reference lab and so on, because, like I said, a decrease in complexity of the testing and availability of the people that can run the testing. But also over the years, these tests have gotten better and better. They have evolved and they continue to evolve and perform. And when we compare them, for a lot of them, we do see very good correlations. And so the drivers towards point of care testing is turnaround time, quick turnaround time in hospital, but also lately, as we saw with COVID, quick infectious disease testing, wanting to know those results quickly has become more and more increasingly important. And it's not just antigen tests now, it's molecular tests that are coming into the market as well. The ability that this type of testing has to be offered at bedside to those people that need it, that may be in locations other than hospital or physician offices, because they may not be able to have access to those resources. I'm talking to the underrepresented population, driving around and accessing those people. And we'll take a look at that. There is more and more people that are being seen at the ambulatory clinics. And like I said, it's easy to integrate, and labor shortage, it doesn't make it easy to obtain more and more certified laboratory scientists from California. So who can perform the testing also weighs into those decisions. So let's start with a quick polling question. I want to just get an idea of in what kind of setting do you at your institution, or does your institution utilize point of care? And I'm looking for things like, is it mostly done where you are in the hospital setting? Is it mostly done in the outpatient setting, ambulatory clinics, physician offices? Is it done in both, none, or some other settings? Okay, so do we have the poll going?
The poll is currently it's having a little glitch, but if you can also just submit the messages in the chat and the comments, then we'll go through the responses just so that we can get an idea of what types of usage of point of care tests do you have in your institution. So just use the chat box right now. Currently the polling is a little bit buggy, so sorry about that.
Yeah, no, you can just type like an A, B, or C or something else just to get an idea of where most people are using it at. Interesting, because we're going to cover, ultimately we're going to go through all these options here. Obviously not D, but yeah, go ahead, Steve, read whatever is available, and then we'll move on, and then we'll keep going.
It sounds that most people are selecting both. So they do both hospital setting and also outpatient ambulatory clinics.
Okay, very good. So that's right in line with where we're going with this presentation. So obviously we offer this as an ongoing service, and there are some things that we want to be able to keep in mind when considering point of care tests. So they can be of different disciplines, hematology, chemistry, infectious disease. So you want to have interdisciplinary committees to assess appropriateness of these types of tests, and also audit tests for user proper utilization. So what becomes important here to audit is to have that test interface, so you can actually get the data out and see how it's being used. And we'll talk about that. Rest assured that staff training is going to be continuous. So you want to have some resources to manage that. And I'll show you how it's a challenge from a hospital standpoint and also ambulatory because of the size of the program. You want to have IT resources for interfacing and be able to pull data and analyze. And also training. Training is key. Training is key, can affect results all the time. So you want to be on top of that. You want to be able to have a system for assessing test performance, performing validations, assessing cost, and test utilization. And also setting up and maintaining good quality control and participating in proficiency testing, internal quality control assessment plans, or something else that you may be doing. And so having things like QC operator lockout. QC lockout, operator lockout can become very useful into trying to help maintain that quality piece within this testing. So jumping at UCLA, this is our Santa Monica Hospital. Is 281 inpatient bed medical center, and point of care testing services about 31 sites and has about 133 instruments. This is our bigger hospital, Ronald Reagan, and we have 520 inpatient bed medical center, even more point of care servicing sites with even more 418 instruments that we support in this. So these are all sites that are hospital licensed sites or clinics. And then we have our ambulatory space, where there are physicians' offices spread out over 300 square miles, over 300 outpatient clinics now and counting. Very dramatic growth. 2 or 3 years ago, before I joined, it used to be closer to 200. So we're picking up a lot of clinics. And primary care clinics, hemoncs, pediatric clinics, urgent cares, they all use different types of point of care. And so this is a different type of challenge of how to try to support this team, and they all have their own licenses that they operate under. So we have the point of care management team for both in hospital and outside of the hospital that supports this operation. It's involved in evaluation of new test requests, validation, training, quality monitoring, etc. And the goal is really to standardize the point of care test offering, disseminate standardized education and training, so make sure that people are using this test as they are supposed to be used, and if there's issues, they got brought up and they get investigated in order, and also ensure regulatory compliance. So before the program was established, especially in the outpatient space with those clinics, it was reviewed and was conducted that only 80% of the clinics were compliant with federal regulation, had the CLIA certificate of waiver, and only 20% with state regulations, because they are required to also register with the state. And after implementation of the program, all of these numbers moved to 100%. So at least getting that regulatorily compliant. But the other goal of the program was, as I mentioned, was to really take a look at the methods that were being used in all these settings and standardize. And they were using at least 4 different types of pregnancy tests. They would have different models, all running the same type of test. Urinalysis dipsticks would be different, all vary with different performance. This is all qualitative. So sometimes the plus with one meth kit could be 2 pluses with another, or could be something even different. Protocols could differ, reading times may have differed too, and so interpretation could differ. So it was decided that we wanted to standardize this to a good offering, and it was done through the materials management to limit how they ordered reagents so that they could only have one choice. And by doing so, not only we could standardize, but we could also get better pricing, because we could buy bulk now instead of individually going through all this. And we had a dedicated resource that serves for this type of purpose. And the other thing that I mentioned to you is that in this space, there is concern about point of care reliability and accuracy. This is no secret. And the doubt is that the results doesn't compare to the central laboratory well, or it's not within accepted variation, for example. And so obviously this depends on the test and the test design, but also depends on how you run the test. Is the operator competent? Because we see this all the time. One operator running precision on one day with one instrument can have a 20% CV versus our CLS, which would be well within 10%. Do they actually run control? And this is something that we struggle even now to nowadays because of the size of the program. And it was found that at the time, there was several testing done with little or no QC, or that they were even expired. There were things that they didn't have dedicated timers that they needed to have dedicated timers for. And so a lot of these reactions are based on time, and timing is important in determining the accuracy of the result, because if you let it go for too long, you can certainly start to have that excessively positivity or false positive, let's say. So when it was taken a look to see how the testing was utilized over a 1-year period by pulling data. And this goes into interfacing. And it was determined that there was a little bit over 100,000 tests that were counted. And at the time, this was vastly underrepresented based on the size of the health system, one, but also inventory. It just didn't make sense. Some tests like monospos, we couldn't find any results that were ordered, but inventory suggested that it's being purchased. So where is it going, right? And a struggle here is that a lot of times some of this testing ends up in the clinical notes. Well, clinical notes, we're not able to pull and analyze the data, and also you're not able to bill for the data. It's not a good place to have, and we are trying to walk away from this practice into a way that we can actually have some capability of pulling this data. The other thing that we could see from this was that most clinics just used a few tests. Most clinics, like here, more than 60, for example, used 1 or 2 tests, and only a single clinic ordered all 10 tests that were analyzed, and the volume on most clinics was low, under 200 a year. And 3 urology clinics make up more than 1/3 of urinalysis performed. So this is important to have granularity on this data, because as a point of care management team, we are dedicating resources and we're disseminating those resources, and we're doing constant analysis and process improvement. So we need to be able to have accurate data interpretation and analysis in order to move on to the next step. The other challenge, we talk about challenges in point of care, was that in a system where free text entry is employed, that they can type the results in any way they want, you end up with a very large number of unique ways of recording those results. Like blood, for example, is positive, negative, or trace. Or you could have things like a P for positive, or pos, or positive, or positive spelled wrong, or dots, pluses, 2 pluses, very large number of different entries that are non-standardized. And by standardizing result entry, a lot of these go away, not allowing that free text entry, basically. So another way to kind of disseminate some standardization across the sites and do things more consistently. So in this space, what are some of the challenges? Well, first of all, you have to be regulatorily compliant. That's what was found. So now we have support for any new clinic that wants to offer point of care testing. We have a dedicated specialist that drives around to these clinics and is consulting with them and telling them what needs to be done. Challenge with training and record of it, lack of competency. This is a big ticket item. And we hope that we can have more and more eyes on this when testing is more interfaced. Missing SOPs, QC and PM logs are not reviewed by the laboratory director. Mislabeling of supplies. Some clinics only had one instrument, and those would have been large volume clinics for that test. What happens if that instrument goes down? What do you do it? Well, you'd have to send it to the lab, so you lose that turnaround time if that's what you need. Also, not enough personnel savvy to troubleshoot if there's issue with those particular instruments. And also lack of established a good middleware, which we still don't have to be able to interface those tests on the outpatient side. Now, moving on to the ambulatory testing, but on mobile health van initiative. This is the Homelessness Healthcare Collaborative launched in 2022 that UCLA is partaking. And so this aims to promote greater equity and get care to those underrepresented communities that normally don't have access to care and cannot get it. So care is provided by medical screening, as preventative care and vaccination, whole family practice care, psychiatric care, mental health services, and also referral to housing and social services. And so currently we have 6 mobile health vans. And so setting this up, since we're talking about challenges, you have to think about a CLIA certificate of waiver and getting that approved with the state and who's going to be the director for that. And also thinking about instrumentation, right? How do you interface it to, how do you get the QC interfaced into the LIS? How do you rank QC? How do you train personnel? Where do you put the instruments, right? Where do you put the instrument in a mobile van? And this van was set up to service shelters in the greater Los Angeles area, encampments, interim housing sites, events, etc. And one of the other challenges is here that getting access to that patient, because in a standard care practice, the testing, the patient goes in, testing gets ordered, it gets done, and results will come in. Will come in within a few days, maybe a few hours if you're in the hospital, for example. But this is where this is tremendously helpful. When you're going to those underrepresented communities, you don't have access to that patient for days. You got to be right there and then and be able to make a decision and come up with results and be able to help, right? So some of the challenges was, well, when you have this instrument and the van is moving along, you stow it underneath, right? And then when you're operating, you put it up on the bench. And if you happen to drop that instrument would be done because some of them can be very small, right? But some of them are not small. And so that presents a challenge. The other challenge is space in a van is very, very limited. Space in a hospital for itself is limited in its own. But in the van is even more limited. And spacing is something that we always struggle with, even on the hospital side. And so challenges with space constraints is something that we also want to be able to overcome. And I have instruments that serve for tests that are used by the point of care department. That's nothing portable about them. I mean, some of them, one of them at least for IPTH, it's a very large system. And it was a challenge trying to get that in to a space within the hospital where laboratories would agree to give up the real estate to get the testing done. So going back to the mobile health initiative, this is a new initiative, and it's a very big ticket item. It has completed more than 27,000 encounters in the first year, delivered more than 7,000 medical psychiatric evaluations, medications delivered to the patients. And I mean, how does this tie in to UCLA? Because this is a broader community initiative and something that benefits the broader community. But nonetheless, we have observed 7% reduction in house patient visiting the UCLA ED, and that is helpful in itself, and also 32% reduction in emergency department visit by high-risk patients. And so what other challenges we face in the point of care? along with the same lines that we have been talking about, we face challenges with resources. On the hospital side, we are always constantly moving and developing and optimizing and offering new tests all the time, right? So I highlight simply just in 1 year alone, one hospital site alone, there's a large number of validations, right? Uh, Blood gases, infectious disease testing, etc. Now, all this is in addition to the quality improvements that needs to be made, right? The competencies, the proficiency testing that we all have to keep up on a day-to-day basis, and all other duties. So it becomes very time-consuming, and staffing just not enough sometimes to keep up with the growing demand and the level of quality that we are asked to maintain in this space. So anything that we can do to automate or streamline processes in such a way that while errors are avoided, so we don't have to spend more time investigating and addressing errors, but also remotely monitor the program so that we don't have to walk around to check paper logs or QC logs. That could be also time consuming, can be benefit. And so with that, I want to talk a little bit about the fact that we still have issues with in a pre-analytical space with ID errors. So the barcode, use of barcode over the, since its invention has dramatically improved patient identification, because now we have labels rather than writing things into tubes and identifying those patients. However, the use of barcodes still has or does result in some errors. And the fraction of those errors can be very small, right? Less than 1%, which seems small, but because we run so many tests, that is still a very significant numbers. And errors in patient identification, they can result in minimally bad things or severely bad things, depending on the type of situation. So you can have something that can lead to like incorrect billing, but also need to resample, and all the way to something that can be adverse outcome for the patient or misdiagnosis and failure to provide proper care. All this dips into resources. So if there are solutions to overcome this, that's definitely another step in the right direction. And there are some solutions where this barcode, instead of being printed, is embedded into the tube. In this particular case is a syringe, blood gas syringe. And like I said, barcode errors do occur. Printers sometimes can print the barcode incorrectly. As a matter of fact, not too recently, we just received a call. There was 2 specimens with 2 labels. One could not be read, and it was because the printer had not printed the label correctly. So the next best thing to a good barcode is a barcode that's embedded into the specimen type. And so making it a more automated way of providing that result to the team requesting for the result. So there can be some reduction in analytical errors, but also the particular offering here, the syringe, has all the other benefits of a good blood gas syringe, which mixes the blood well, removes air bubbles, and reduces the risk of clotting samples, hemolysis, and needle stick. So if you're in a setting where your blood gas is moving from your units into the core lab, and the label needs to be put on, and that needs to travel, and there's a number of issues with that. Obviously, we try to retrain first and try to resolve those issues. But if that's something that persists, having something that has a label on it could be the next step forward. And of course, you'd have to register this at the bedside to match it to the MRN of the patient. And of course, you have to do things in a fiscally responsible manner, make sure that the costs are taken into consideration. There's real benefit to this. But it's good to know that the opportunities does exist for a quality improvement project. So the last part of this is to really take a look at test interfacing. And test interfacing can help us dramatically in what we try to do in this particular space, because we are trying to monitor a very large program that does a very large number of tests. So before we go into that, I don't know, Steve, if the poll has resumed, but the next question I have, I'm going to get an idea, is at your institution, are your point of care devices interface to the electronic health record system? And what I mean is that usually there's a middleware in place and the instrument will send results to the middleware and then into your LIS, which could be Epic. For us, it's Epic. Is that already set up, and is that set up for all the tests? Yes, it's all interfaced for every single thing. It's mostly interfaced. Few of them are interfaced. None of them are interfaced. We're working on it. We need to get some more resources first.
Yep, if anyone can just type in A, B, C, D, or E in the Q&A, I'm reading through it right now. This will probably be the fastest way to do it. I'm already seeing some full responses right now, so thank you. It looks like a good mix so far of A and B. So yes, they're interfaced or mostly interfaced so far.
Sure. Yep, those are definitely the most popular answers. And it's really good that it's A and B. You don't want to be closer to C, D, and E. Okay, so point of care connectivity. I mentioned this a little bit, but just to touch on a little bit more, results reside in Epic and they travel through RAS. In the point of care space, they travel through RAS, but only for those instruments that are interfaced. And so connectivity is important because you want to be able to send information back and forth between instrument and middleware. There are some other important aspects here, and I touched on this a little bit at the beginning, but a QC lockout. And this is very important in the hospital because these are hospital licensed clinics. We don't want them to run the instrument if the QC didn't pass. Operator lockout, if they're not competent on running the test or they haven't done their competency or annual training, then we don't want them to run that test. They need to do that first. So having these features can be important. New lot configuration, getting remote access to the instrument. I mentioned at the beginning, Reagan is a big place with multiple sites spread out across the whole hospital system. So walking can be very tough to all these sites. So getting access to be able to access those instruments can be pretty important. Seeing data like who used it, patient ID, be able to look at the results, the QC, the calibration, the maintenance of that instrument. Those are all very important. It can be very handy. Be able to keep record and also really to be able to monitor the whole program. We have more than 3,000 operators. We want to be able to do the things that we say we're going to do when maintaining quality in this program. And so the thing here is that if something is documented in the clinical notes, if the results is documented in the clinical note, that is very hard to capture. We cannot pull those results. So EHR documentation, it really helps us to improve patient care, ensure continuity. We can assess needs and predict point of care needs based on testing, test volumes, where it's used, where it's not used. If it's not used, we may want to move the testing somewhere else. If it's used, we may want to provide additional resources. It can help us identify product recalls or results from product recalls. Not too long ago, we had a recall on A1C, and the doctors wanted to know all the patients that were affected, and we were able to tell them that for the tests that were interfaced. But there are a number of tests that are not all interfaced, and those that are not interfaced, it becomes very tough to provide answers. We have idea of when certain lots were shipped and put into place, but to be able to narrow that down, really, you have to go back into the paper logs, and it becomes a very manual process. On the ambulatory side, tests are not interfaced, and this is a big challenge. On the hospital side, most big volume tests aren't interfaced, and there's a handful of tests that are not interfaced. And that mainly because of the offering. Some tests we can never be able to interface because they don't have electronic capability. And some tests we have been, and we are continuing to interface even and even more. So for the results, they reside in Epic. However, we do have some requirements to make sure that at least periodically we check and make sure that the results are entered correctly, right? And so if a test is not interfaced, that becomes a manual process. And especially for those tests that we have set up, IQCPs in place, we have to do this. And so just showing a snapshot for a test that prints out a result on a piece of paper. We're looking at a hemoglobin of 9, and you would match that with something from an EPIC, and hopefully it looks like a 9. And in this case, it was a 9, and so that result is confirmed to transmit correctly. But you can see that you have to go into the paper logs, and this becomes a manual process, and this can be tedious. And there are instruments that don't even have functionality to have a printout available, so you have to look at the screen. And so it can become very labor intensive and difficult to keep up. So we have tried to do what we can with some of those tests that are not interfaced all the way to have kind of like a hybrid, working with IT to get results pulled from flow sheets. So having the team enter the results in EPIC into an area that's called the flow sheet, rather than just in the clinical notes, for example. And those results can be pulled into a PDF report, and they can be reviewed a lot easier there and matched to EPIC a lot easier, and matched to the printout a lot easier. Because the other thing that we have to realize is the EPIC view that our CLSs look at sometimes is not the same EPIC view that some of the RNs or the doctors have. So it can become a challenge to navigate the space around there. I mean, but the alternative, just to talk about interfacing, is to have test interface, for which we do, several of them. And this is great because results go through the middleware, and we can see that some results are uploaded successfully, like here with the checkbox. And if you click on that, then you can see the location, you can see who ran it, you can see the sample ID, you can see the patient that belongs to, and you can see the results, and you can compare those to EPIC if you really wanted to. And when results are not uploaded successfully, you could also see that. And that could be because there's no chart or the patient moved around. There could be some various reasons for that, but at least you know. The other thing that you can see is that you can see right off the get-go which instruments have connected correctly, right from the beginning of the day. And you can see which ones have not connected correctly. And those that have not connected correctly, you can be proactive and try to troubleshoot that issue. Maybe it was a loaner, maybe there are some issues with connectivity, so that when actually a result gets run, it will go ahead and be transmitted successfully. And we can monitor the program in terms of competency. We can see operators, active operators for a particular test, and we can see what licensure they have. In this particular case, they can run this particular instrument. We can see when the certification expires and when they need to do the next training. And we can also be proactive, assign training online, and make sure there's no gaps in between, and make sure really that things are not run when they're not supposed to be running this. That's why those QC operator lockout, QC lockout are important. And the alternative of this is, like I was mentioning, a manual tests. Some tests that are manual need manual review, and this is tough, especially if the results are entered into notes. So in this particular example, I believe this is gastrocult, but you run QC, you run the patient, and you need to record those results. And we are working on a setup so that those results can actually be entered in specific sections, like I mentioned before, of EPIC that can be pulled. Because right now, if it's all manual log, then it becomes a manual process of checking for results, archiving them, and data accuracy. But FlowCell, it is possible to have IT resources and insert places in flow cells where RNs or even doctors who runs this test can enter the results. And when they can enter those results, then they can enter the QC there as well. We can pull those. We can pull those and we can monitor the program. And that becomes a lot easier than doing the manual work. So this data resides in EPIC, as I said, and also resides in the middleware system. And they can be stored there for very long periods of time, but there's always incentive and encouragement to purge the data because it slowed down the system, et cetera, et cetera. However, having information on the middleware about the test that was conducted can be very useful. Because like I mentioned in the case, there's a product recall, for example, we want to know which patient was affected. So we want to know which lot was used to run and during what time. And if we have that information that we can actually get from the middleware, we can trace that back easily. Otherwise, it becomes a guessing game and it becomes a very manual process. And so that is another functionality that we do want to retain and maintain there. So test interfacing, it's a big ticket item. And test interfacing, it's important to have for both in hospital and for outpatient clinics. And in the outpatient clinics, we currently don't have it, and it's going to be a long project. We are working on it, and it's sort of like a one clinic at a time project because you have to really provide data ports and cloud storage and storage for the data. So it's not easy. And I wasn't aware of this, but connectivity is very expensive. So doing this is also a costly project. And by automating things, automating things that we have been talking about, ensuring that competencies are run on time, and all those little things can help our team with the work that they have to do every day, which is very labor-intensive work, and so they have enough time to do the quality that we want to do. Now, to add on to all of this, UCLA bought another medical center. It's a 270-bed facility, and we get to go through it all over again. They are on a different LIS than what we are. So the first step is to convert them to Epic. Second is take a look at their offerings. It's going to be an interesting opportunity. And obviously, we want to standardize as much as we can. We want to make sure that our SOPs and quality monitoring process is aligned and it's in a good place. And so what is the future? I mean, we talk about the future, where we want to be from here. Point of care testing. We want to be doing what everybody else in the clinical lab and across the country wants. We want to be able to get a test result, make sure that the right test is run it, and report the results. But we want to do it in a way that we can actually monitor the program. We want to have testing interface for both hospital and outside of the hospital clinics. And we want to be able to have remote access to that and also have competent and trained staff perform this testing. And so point of care testing in itself as a single test, this is not hard to do. This is simple testing, right? It's wave testing. For a lot of it is wave testing. And it's not hard to do. But in its entirety of the program, where we have dozens and dozens of tests across multiple sites that require, different types of capabilities. Some tests and test systems and instruments are able to interface with the middleware, while some are not. And getting those to interface, it becomes a very big job. So the larger project to accomplish this for the whole system, this is very difficult because of its complexity. But point of care testing in itself is not difficult to achieve. So how we get to that is through all the steps that I've been kind of mentioning. It's a slow journey, moving forward one step at a time to be able to monitor the whole program successfully. And so with that, I'd like to thank the section, the point of care at UCLA, led by Dr. Omai Gardner and the supervisors, and also our specialists who do most of the hard work, some of which I talked about here. And with that, I'll be happy to take any questions.
All right. Feel free, anyone in the audience, to post in the Q&A if you have any questions. I do have some that I see here. So in this case, Dr. Matucci, I'll ask the first one I see, which was a question that says, you mentioned several advantages and challenges to point of care testing in your talk. So in your opinion, what has been the most significant advancement or improvement to point of care testing at UCLA?
Right. Most significant has been the formation of the point of care management team to oversee both ambulatory and in-hospital sites, and are really providing support for the ambulatory site, and the ambulatory site extending that to the mobile health initiative with a mobile van, really getting that care to the underrepresented community and getting it to a point, even though this is just the start, getting it to a point that we are already starting to see advantages and reduction in number of ED visits and high-risk patients visiting our own medical centers. I mean, it starts to already speak to the success of some of this and the great work that this team of laboratorians, nurses, and physicians are already doing in this space. And we certainly hope this continues. And yes, some of the challenges that they had to overcome to be able to offer those testing to this underrepresented community.
Thanks for that great response. I see another question here. It seems that out of all the examples you've shared in this talk, what has been the most common pre-analytical error that you've seen?
Most of the common pre-analytical error. Well, specimen mislabeling is always on the table, not just on the point of care. I mean, like I said, it came up last week. That's why I remember that first. But I think an area of challenge in this space is having eyes on the program and really making sure that things are QC'd when they're supposed to be QC'd. Staff is trained. And the challenge is that in a hospital setting, we can do that because we are fairly there. Sometimes there's gaps in there too, but on an ambulatory setting, our role is more of a consultant. So we have resources that are dedicated to these centers to train them, to guide them with licensure, but it's really up to them to make sure that they do those things. And that's on their CLIA certificate. Monitoring that is very different because we do have someone that drives around, but they can't be at over 300 clinics every single day, over 300 square miles distance. I mean, it takes an hour to get 10 miles in LA on a good day. So, yeah.
Got it. And then the next question we see here is, what is next as far as improvements go in your point of care agenda?
Right. Our next big ticket item is really to focus on those non-interface tests. We do on those and we've been trying to do this hybrid way of trying to get at least some results in Epic using flow cells for those that we haven't had the chance or are not able to interface, but really on outpatient clinic. That is our next big ticket item. None of the tests are interfaced. And like I said, I was ignorant in this space, but connectivity is very expensive. So we're trying to find a good working model, a fiscally sustainable model that can allow us to have this connectivity on these ambulatory clinics, and we can monitor the program online.
That's great. I see another question here. In your opinion, do you see the hospital staff shortage improving? So this is based on what you mentioned about the staff challenges in healthcare today. Do you see it improving in the near term or long term, or is it holding steady, or do you believe it's still getting worse? And then there was a follow-up to this where, do you think there are ways to implement maybe some AI to some extent to increase productivity and counteract this challenge?
Right. It's a tough question. We're certainly heading in directions where we are trying to alleviate those problems, right? And so the other next thing that we need from that is what's happening with all the people that are planning on retiring, when they are going to retire, right? I know in California, the training programs are limited because to train a CLS, you have to be from a training program. Other states are moving towards the same licensure. Now, those programs in here, they're expanding a little bit more. So more programs are getting accredited. They're taking a few more students over the past decades. They have increased those numbers. But really, the challenge is a balance, right? It's a balance in versus out, like which one is increasing more. I would say in this new modern age and day with AI and automation, which is been dramatic for the clinical labs. I mean, in the clinical lab space, we've been working this in the past 2 to 3 years, and we're mostly all there with all 3 of our sites, including the reference testing lab, where we have total laboratory automations, and everybody else is embracing this. So it's freeing up that hours in that space. So I think some savings will occur, and maybe there can be some redistribution. A lot harder to achieve TLA in the point of care space. I mean, we have so many different types of devices and that needs to go into all these rooms and units. And so that is tough, but maybe some shift can occur as the automated clinical lab becomes more automated, and they're able to save FTEs, and then some of those can be spared towards the point of care space. And certainly there's hiring there, but currently the market, based on my understanding, is pretty tough. It's still a workers market. The workers are in high demand. We're still losing people to competitors that offer just better compensation, and we don't want to lose anybody, and we try to do our best to keep our own employees, but I would say in the maybe longer term future, I could see some of this trickling more in the short to medium term future. I think we're going to be still experiencing the same pain points of shortages in healthcare workers and doing this work. Yeah.
Sounds good. Thanks for that input, Dr. Matushi. I think that we're getting really close to wrapping up this session. It's getting close to the top of the hour. If you have any more additional questions that you would like to submit, feel free. You can do so, and we can also get back to you directly after the webinar. So in this case, it now concludes the live broadcast of this webinar. Thank you all for participating and for the great engagement. We hope you found this information insightful. Hopefully, you may also share and discuss with your colleagues any topics that you found were important for your own clinical setting after this webinar. And as we end this broadcast, we will upload and make this webinar available to be viewed on demand on our webpage. We also hope that you may join us for other future educational events as well. And thank you all again. So for now, goodbye for now. Thank you.